Hello and welcome. I'm Elisa Hernandez, a librarian at Stanford Health Library. Thank you for joining us for our talk, Back on Track, Managing Low Back Pain. It's my pleasure to introduce our speaker, Dr. Joseph Liao. Dr. Liao is a board-certified anesthesiologist, pain management specialist, and clinical instructor at the Stanford University School of Medicine. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Liao will answer as many of those as possible. Over to you, Dr. Liao.
Fantastic. Nice to meet you, everyone. Thank you so much for joining us this evening. I'm really delighted to talk about low back pain, the treatment of low back pain, and also some developments in the treatment of low back pain space that could potentially be helping you as well as those around you. So let's go ahead and share my screen here. So I'm one of the clinical assistant professors here at Stanford, and I'm an anesthesiologist and pain physician specializing in neuromodulation and minimally invasive spine treatments. So to begin, I just want to emphasize that we are outliving our hardware. And what I mean by that is that the life expectancy has increased significantly since the 1800s. Back in the day, people are fortunate they lived to the early 30s. Nowadays, the average lifespan has increased by over 40 years. So the average lifespan as of 2023 is actually 73 years old. So really, we're starting to outgrow our body in a certain sense. And because of that, it is normal to develop chronic pain. So let's talk about chronic pain in general. This is a 2023 national survey. And what they found was that about 24% of people in the US experienced chronic pain. And if you divide it up by men and women, what we found is that 23% of men had chronic pain and 25% of women had chronic pain. And what this really shows is that regardless of sex, everyone at large is experiencing some degree of chronic pain. That's 1 in 4 people. That's higher than diabetes, heart problems, high blood pressure, cancer. It really is an epidemic that we have across the country and around the world. Now, I also want you to pay attention to high impact chronic pain. And what high impact chronic pain is pain that causes limitations to your functionality. So that's things like performing activities of daily living and also being able to live a normal life. And you can see that overall, about 9% of people across the country, on average, are experiencing high impact chronic pain. So this is a breakdown by age. As you can see here, in the 65 or older age group, 36% of people experience chronic pain in general. And for high impact chronic pain, that's about 14% of the population. In the 45 to 64-year-old group, that comes out to about 28% of people who experience chronic pain, and 11% of the population has high impact chronic pain. And even in our younger demographic, from ages 30 to 44, 5% of people, comes out to about 1 in 20 people, will have high impact chronic pain. So this is really becoming a silent illness that people are not recognizing, even though it's happening all around us. So let's talk about chronic low back pain specifically. I always tell people it's not a matter of whether or not it's going to happen. It's a matter of when it's going to happen. And why this matters is because you really need to place energy where it's fruitful. And what I mean by that is there's what matters and what we can control. And then we place our energy somewhere in between there. And that pertains to chronic low back pain as well. So this is a 2019 census study where they evaluated different sources of chronic pain. And what they found is that 40% of all chronic pain involves the low back. And about 36.5% of chronic pain is in the lower limb. Now, the reason why I highlighted the lower limb in addition to the lower back is because many times lower limb pain is actually derived from spinal degeneration, and that's why they kind of go hand in hand. So here's another slide that just shows the same census study, but also breaks it down by group. And what you can see here is that in the 45 to 64-year-old age group, over 40% of people experience chronic pain. And in the 65 and over group, over 45% of people experience chronic pain. So this is a very intriguing study. And this is a study that looked for spinal degeneration in asymptomatic populations, meaning that this is for people who do not experience any sort of pain, but they scan their MRI. And what you see is that um, the majority of people after the age of 50, 80% of patients will experience disc degeneration or disc height loss. You'll also see things like disc bulging, disc protrusion, facet degeneration, and shifting of the spinal column at various age group. And the numbers are surprisingly high, even for people who don't experience pain. So what does this mean? Why is it that some people who have degeneration experience pain and others don't? Well, what this tells us is that degeneration does not always equal pain. And that means that low back pain is very complex and it's oftentimes multifactorial. So again, we are outliving our hardware. And one thing that came to mind happened a couple years ago. I remember I had a patient who brought an MRI CD for me to upload, and we were trying to upload into a system. Well, it was a very new computer without external adapter. And what we found is that a lot of the newer computers actually don't read the CD-ROM. And so this is something that has changed over the last 5 years. Prior to 5 years ago, everyone's using a CD-ROM for everything. If you go back even further before, back in the day, the cars had audio cassette players. But around the mid 2000s, what ended up happening is that many vehicles, many music artists started releasing things via CD-ROMs. And so because many vehicles did not have the capacity to accept audio cassettes, what they actually placed were actually these audio cassettes with an adapter to a CD-ROM that then would allow you to play music that's up to date. And I want us to think about the body that way. Even though our body may become more dated, there are different things that we can do so that we can continue to do the things that we love and live a happy, healthier life. So uh, Benjamin Franklin once said that there were two givens in life. I want to make an edit. I think that there are three givens in life. That's death, taxes, and low back pain. And this is another back pain statistics. 8 in 10 Americans will experience low back pain at some point in their lifetime. If you extrapolate that to around the world, that means about 620 million people around the world experience low back pain. And 5% of people are strongly struggling with back pain, and they go on to develop chronic back pain. And this is a big burden on the US economy because the annual cost of low back pain is about $635 billion. Now, I always like to joke with my patients, the other 2 in 10 have either forgotten that they had low back pain at some point or they're lying. So low back pain is complex and multifactorial. I like to tell people that the more components you have, there are more opportunities for part failure. So on the left side of the screen, this is a Toyota Camry, one of the most reliable vehicles that can probably go up to 300,000 miles and still run because they have very basic components and it gets the job done. On the right side of the screen is the Italian supercar, and these vehicles require a lot of upkeep, and oftentimes small oil change issues can develop significant engine issues because there are much more complexity to the engine system and there's much more moving parts. And because of that, there are more potential for part failure and difficulties with operating the vehicle. So if we were to look at the actual spine anatomy, the spine anatomy is very complex. When someone tells us that they have low back pain and they point to a certain region, it requires a very thorough physical exam and correlating that with imaging findings because you can see just off of the skeletal structures alone, there are many components. So for example, the front of the spine has a vertebral body and the disc. The middle aspect of the spine here has a spinal canal, and this doesn't even include the spinal cord, the nerve root. And in the back portion, you have these facet joints, you have the spinous process, you have all these various ligaments that holds the spine together. And furthermore, if you go further down the spine as a continuum, there's also the ilium and the sacrum. Of course, there's the sacroiliac joint that can all contribute to low back pain. And when we think about the spine anatomically, we divide it into thirds. There's the anterior third, which is the front of the spine or the side that is closer to your abdomen. And then there's a middle column that houses most of the neurologic structures, such as the spinal cord and the terminal nerve roots. And there's the posterior elements, which includes some of the facet joints, which are these articulations that help mobilize the spine and help stabilize the spine, especially when we're arching our back and twisting, as well as ligaments and the spinous process, which are the bony protuberances that you can feel when you touch the back of your spine. And that's just the musculoskeletal components. There's also many attachment points at various points that helps hold our entire skeleton together. And just muscle groups alone, there's at least over 20 different muscle groups that help keep our spine together. And these are the neurologic structure or the soft tissue structure. Here's a spinal cord. The solid part of the spinal cord terminates at about the L1 level for the average human. And after L1, it branches off into something called the caudal equina, Latin word for the horse's tail. And they are these nerve roots that then run down in this cushioning sac called the caudal equina CSF sac. And what happens is that these nerve roots come out of the neuroforamen, which then proceeds to develop into peripheral nerves, which are closer to our extremities. So, did you know that lower extremity, hip, and buttocks pain can also be coming from your spine? And the reason for that is because sometimes there can be nerve impingement higher up or more retrograde. So it's closer to the spinal cord. And sometimes it doesn't take a lot of disc degeneration, crowding, increased pressure in the area to cause referred pain or radicular pain, or also known as radiating pain, that extends down to the lower extremity, the hips, and the buttocks. But wait, there's more. So for the people from previous generation, there's this gentleman named Billy Mays, and he used to do infomercials, and he always says there's more to it, and that's the fact. And for the younger generation, this is a scene from The Notebook where Ryan Gosling and Natalie and Rachel McAdams were talking about how things were not that simple because there are layers to everything. So what is pain exactly? Well, the International Association of the Study of Pain, which is the international governing body on the study of pain, defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual potential tissue damage. Now, what I want you to turn your attention to is that it's an unpleasant sensory. So it doesn't necessarily have to be sharp or burning pain. It could be any sort of discomfort. And it's also emotional experience. So it's not just the pain itself, it impacts you on a daily basis. And it's either associated with actual damage or it resembles or presents similarly as though you had some sort of tissue damage going on. So how do we perceive pain? Well, whenever we perceive pain, oftentimes it starts in the peripheral. So there's a chemical reaction that happens when we feel pain peripherally. It travels up the peripheral nerve. Then from the peripheral nerve, it coalesces at the dorsal root ganglion, which is just outside the spinal canal. And at this coalescence point, what ends up happening is that it travels through the dorsal column and other elevator tracks to get from the spinal cord all the way up to the brain, and from the brain to the processing center where we ultimately perceive pain. And knowing this is very important because by knowing the pathway in which pain transmits, that gives us many opportunities to try to treat pain at various levels. You can treat things at the level of the periphery, or you can treat things at a midway point, or centrally at the spinal cord, or at the level of the brain. I also want to turn some attention to acute low back pain, meaning short-term low back pain. So 90% of people who experience acute low back pain will recover within 6 weeks without loss of function. Oftentimes, the residual, less severe back pain will persist for about 1 to 3 months. But chronic pain is different from acute low back pain. So the difference between the two is that in acute pain, the duration is typically less than 3 months. There's usually an active pathology or active healing that is still in progress. And there's not too much central effect at the level of the spinal cord or the brain, or if there is any, it's typically short-lived. And the treatment for that is to essentially wait for the underlying healing to complete. So an example would be someone who receives surgery and someone develops incisional pain. Well, as the nerve endings start to grow with each individual day, what ends up happening is that your nerves become less sensitized over time and they start firing off correctly. Now, to contrast that, there's also chronic pain, which is pain that's been going on for 3 months or more. And that's when the primary components of healing have already been maximized, or the residual changes to a nerve pathway has already stabilized. And the central effects are typically ongoing. And so in this type of paradigm, what we try to do is we try to treat the symptom while maintaining functionality and improve the quality of life. And so to talk a little bit more about the circuitry, on the lower left side of the screen, this is a reflection of different types of electrical wires. There's a larger bundle that houses individual wires, and each individual electrical wire fiber has a different task. Well, this is exactly the same as the human nerves. So if you think of a large nerve, it's almost like a bundle or a thick wire. But within that wire, there are these individual nerve fibers that are responsible for different things. Some are responsible for motor function, others are responsible for sensory changes such as pain, pressure, temperature. So over time, as we age, sometimes the nerve fibers may not fire correctly because the components of the individual nerve fibers may change due to pathology or due to normal degeneration. And the other item I want to turn the attention towards is something called central sensitization, where there's a central effect of chronic pain at the level of the brain and the spinal cord. So what this is that when there's a chronic peripheral source of pain, it ends up ramping up the signals at the level of the spinal cord. And when the spinal cord is ramped up, it sends more signal to the brain that processes pain. And when the brain is under significant stress and frequent stimulation, that tells us, hey, we're in a lot of pain. It reduces the amount of descending pathway inhibitory function. So what that means is that it basically turns off the regulator that helps turn down our pain dial. And when that happens, the amount of pain that you feel amplifies, and it becomes much more easier to activate your pain. And so that's why some people over time, when they have pain in the same area, even if everything looks pretty stable on MRI, their pain may increase because at the level of the brain, what they're perceiving is amplified. So the treatment for pain is using a multidisciplinary paradigm. So I tell my patients we're using the 4 Ps of treatment. That involves physical therapy, pharmacologics, procedures, and psychological support. And depending on the condition, depending on the patient, uh, uh, one treatment may be more applicable than the other. So again, the treatment needs to be very tailored. When we look at a patient, it's almost like looking at the parts of a car. If there's something wrong with the engine, your treatment is going to be very different than if there was something wrong with the wheels. And just to go back to that nerve pathway, depending on which part is more sensitized, we try to address that region first, because different problems and scenarios require different treatment plans. And ultimately, we want to find the right treatment for the right patient and also at the right time. So let's talk about more tailored individual treatment. So there are certain medical conditions that make specific treatment riskier. Sometimes people may have difficult anatomy that may put them at high risk for complications for procedural-based treatments. For other patients, they may have other medical conditions where they may not be able to tolerate medications very well. So we really need to make sure that we understand the patient because it's not a one-size-fits-all type of approach. Additionally, every insurance company is different as far as what they're willing to cover from a treatment standpoint. And furthermore, patients may need to be psychologically and physically optimized before we can consider a treatment. So the treatment options are on a spectrum. On the conservative side, there are medications, physical therapy, and psychological support. Then the next step up would be injections. That would be things like diagnostic blocks and therapeutic blocks or steroid injections. Um, uh, Now, there are other treatments such as radiofrequency ablation, thermal ablation, things of that nature, where we can try to turn off the nerves for longer periods of time. And the next step up would be things like neuromodulation, as well as minimally invasive spine surgery or minimally invasive spine procedures. And there's also traditional open surgery. And we'll kind of break down each individual component in the coming slides. So again, one size doesn't fit all, and the treatment is on a spectrum. There are conditions where you definitely need to get traditional surgery because the other treatments just aren't going to cut it. And there are other treatment options where something like an ablation may be overkill when it could be simply treated with medications, PT, and psychological support. So we really want to be very mindful of our options and really think about the four legs of a chair. So we want to do the right treatment for the right patient at the right time. And the intriguing thing about the pain management field is that because it is such an epidemic in every part of the world, there's more research and developments in the treatment of chronic pain. So as time progresses, the treatment options evolve, and the treatment options are becoming more safe with easier recovery, and they're also more targeted as well. The other thing I want to highlight is that chronic pain treatment of the spine specifically is typically palliative. So baseline components of healing have largely been maximized or stabilized in chronic pain of the spine. However, it is important to note that pain does not suggest that a component is actively being damaged. If there's degeneration in one area, then oftentimes there's also degeneration in surrounding structure because everything is a functional unit in our body. And so the goal is to try to improve individual variables. And oftentimes, one does not need to treat all the possible pain generators to facilitate an increase in quality of life and functionality. So here's the fountain of youth. Since the beginning of time, many people have tried to look for the fountain of youth to try to live happier life and longer lives. But what we found is that really to live a happy and long life, it requires quite a few components. You need to have balanced nutrition, you have to be well hydrated, you have to get enough rest, you have to have a consistent schedule, and you need to exercise, and you also have to have an optimized mental health. Now, the treatment of chronic pain can facilitate various key components of that. By treating chronic pain, you can be more active, where you can then work out. By treating your chronic pain, it can improve your mental status. And also, treating chronic pain will ultimately allow you to rest better and have a more consistent lifestyle when you're well rested. So, treatment of chronic pain can help people live happier, healthier, and longer lives. And that really is part of the recipe for the fountain of youth in modern age. So, again, we want to prioritize the functionality because chronic pain changes how our central nervous system is processed at multiple levels. And the interventions that we facilitate are often a means to get us to get to physical therapy and restore your life. So let's talk about physical therapy first. What physical therapy does is helps re-engage the anatomy to optimize the alignment of the spine and helps strengthen the adjacent muscles. It also helps you with flexibility and mobility and ultimately helps stabilize the spine. So if you look at the bottom right image here, this is a grade 1 spondylolisthesis. What that means is that there's a less than 25% shift of the spine. So this top vertebrae level is slipping over this lower level. Now, this is the mildest form, but even with the mildest form, you start making some changes to the disc. You also start to put some shearing stress along the articulations in the back, and you're also narrowing the space around the nerve root. So even a small amount of mobility in the spine that's unintended can cause significant symptoms that one experiences chronically. So it's really important to take advantage of regimented physical therapy programs because they can help stabilize the spine by strengthening up some of these adjacent muscles here. And after a regimented program, this is typically followed by a longer-term home exercise program where you don't have to go to a center and you can just continue these exercises at home. And so physical therapy is at the heart of everything. It's the first treatment option before you consider any sort of injections. One, it's an insurance requirement. But number two, if you're able to get better and let your body heal yourself, you don't necessarily need anything more aggressive than that. And the other important thing is that after we facilitate some of these interventions, it's important to reinitiate physical therapy because after we do a treatment and your pain improves, you're able to move differently. So now your body is at a new set point and it's playing catch up. And by engaging physical therapy, we prevent future injury from occurring. Let's talk about medications. The goal of medications are to help reduce symptoms, but medications do not alter the biomechanics. There are certain medications that may help reduce pain resulting from inflammation, and some can also help stabilize nerve conduction and modulate pain centrally. So you have to weigh the benefits of medications versus the risks of side effects. And with medication, it's a less targeted approach. With the exception of some focal patches, most or certain targeted formulations, most medications are absorbed systemically and targets every cell in the body. But medications will target things either in the periphery or centrally at the level of the brain and the spinal cord. And even things like antidepressants can also help reduce pain by modulating things centrally at the level of the brain. So let's talk about pain psychology next. There are many opportunities to retrain the brain to process pain differently because believe it or not, your neuronal wiring and your physiology changes over time. And by using psychological tools, you can change how your brain perceives pain and processes pain. And there are common psychological conditions such as anxiety and depression that can cause the brain to have decreased inhibitory state or increased excitatory state for pain. So treatment can decrease the pain that is perceived. And furthermore, there are psychological exercises that help manage our perception of pain. Some very simple things that you may have heard of would be reframing. So instead of saying, I can't sprint anymore, you can say, I can walk. Or you can also reduce fear avoidance. So that's knowing that in chronic pain, everything has been optimized and that there may not necessarily be anything that's exacerbating. So you can move because even though you're perceiving pain, nothing bad is actively happening as you're moving. And by doing that, by not having as much fear avoidance, you're able to do more, you're able to do physical therapy, and you're able to help your body recover itself. So a question I want to raise to the audience is, I want you to think about this. How do we see? And when you move your leg, how are you actually moving your leg? And were you picking up a cup or when you're typing on your laptop, how are you able to feel the keyboard and how are you able to feel the cup on your lips so you know when to take a sip? And I also want you to take a look at these images here because there's a point to be made here. So I want you to take a look down and think about the clothes that you're wearing right now. Now, notice that you've been wearing your clothes all day and you probably felt your clothes on your skin earlier today when you were putting it on. But throughout the day, you've no longer noticed that your shirt was on your skin. Now, the reason that this is happening is that our brain is constantly assessing the sensory input and also churning out an output that tells you what you're thinking about at a particular moment in time. So even though your skin is actively touching your clothes, your brain turns off that stimuli because it knows that you have other more important things that you're paying attention to. So in the upper left corner, here's an image of someone in combat. Sometimes when people get injured somewhere in the acute phase, they're still able to tough it out and go through things because there's an adrenaline surge that allows them to go into survival mode. But oftentimes, and the majority of times actually, after the injury occurs and things stabilize, that's when people start to feel the most pain during combat. And that's because when your brain is under a different level of stress, it'll start to triage what's important to your sensory perception. And the upper right corner is a view of a vacation. And notice how sometimes when you're on vacation, your pain is not as painful. And also in the bottom right corner, notice how sometimes when you're sleep deprived, your pain is much more noticeable. And the reason for that is because the brain is constantly assessing things. So your mind and your brain is the ultimate endpoint of everything that you're feeling and everything that you're doing. And for a basic activity such as seeing things or lifting out your legs, it all happens at the level of the brain. So what we know from neural imaging, specifically functional MRI, is that different parts of our brain will fire off depending on your activity. And in chronic pain, the way that the different parts of our brain fires off will vary over time because of this constant stimuli that occurs. And this is another image that highlights the association between depression and chronic pain. And you'll see that there's quite a bit of overlap, even though there are some differences in the parts of the brain that lights up. When the conduction is transmitted into the brain and throughout the brain, there's a lot of overlap, and sometimes they will activate each other. So let's shift gears and talk about injections. Injections can be diagnostic or therapeutic depending on the condition. Diagnostic injections are to help guide longer-term treatment for non-surgical as well as surgical treatment. Therapeutic injections can help manage pain, but they may need to be repeated intermittently. And these injections can target the muscles, ligaments, sensory nerves, as well as the nerve roots. And typically with injections, they don't involve incisions, and they're usually performed in outpatient or in-office settings without the need for sedation. And with modern treatments, we typically perform them under ultrasound or fluoroscopic guidance. So the bottom right is an image of a trigger point injection where they are intramuscular injections. And the bottom left image is talking about cortisone shots in your spine, also known as epidural steroid injection. And there's quite a few different ways in which we can try to address those nerve roots using a variety of approach. So next level of treatment would be ablations, also known as RFA or radiofrequency ablation. And the goal is to try to treat the nerve with thermal energy. So when you heat up the nerves or when you cool down or freeze the nerves, those nerves will be turned off. But the majority of nerves, because they have these protective lining, those nerves will grow back. So when we do radiofrequency ablation treatments, most nerve targets will require a repeat procedure once to twice a year. The good thing about ablations is that typically it doesn't involve incisions. It's typically done in an outpatient setting and it requires little to no sedation. And it's usually performed with fluoroscopic and ultrasound guidance. So on the right here, this is one of our most evidence-based and common treatments. This is medial branch radiofrequency ablation. And the medial branch nerves are responsible for sensing arthritis in the back portion of the spine. So that's pain with arching your back, extremes of bending forward or twisting motion. And by hoping to dial down the pain on those nerves by heating them up or freezing them, we ultimately perceive less pain, which can then allow you to increase your range of motion and exercise more with less pain. Now, there's a very important part of these intervention, and that's the technical aspect of it. By having an optimal placement and having better radiofrequency ablation settings, such as temperature and duration, and as well as the medications we use before and after the ablation, that can affect the efficacy of it as well as the durability of the treatment. So let's switch gears. Do you know anyone with any of the following implants or accessory devices? Do you know anyone with a pacemaker to help them continue to live with underperforming heart? Do you know anyone with a hearing aid that allows them to hear better and converse with you? And have you ever seen anyone walk around with a glucometer? And do you know of anyone who have had artificial hip replacement? And the reason why I bring this up is because technology is changing the way we're able to live, and it's ultimately improving our quality of life. And in chronic pain, there are different technological advances. Some are implantable and some are non-implantable that can really change the trajectory of our functionality and our pain. But we'll talk about some of these treatments that have developed over the past 5 to 20 years. Some are older than others, but the ones that we perform at Stanford have been well vetted and have a lot of evidence behind their efficacy. So first, we'll talk about neuromodulation. And I always like to tell people the future is already here. These treatment options are available, but not all institutions facilitate these interventions because they require more expertise and they require more experience. So neuromodulation is using stimulation-based therapies to treat chronic pain. And the neuronal pathway can be targeted at different locations. And what these devices do is that they help dial down the pain that is experienced. And there's also a special type of neuromodulation called restorative neuromodulation. And what this type of neuromodulation does is that it reduces pain and also helps re-engage muscle groups that are underutilized or have fatigue due to chronic pain. And so we're going to talk about the gait control theory and how it applies to neuromodulation. Think about the last time you had a mosquito bite. If you recall how itchy it is, the natural tendency is to scratch the area or to slap the area. And the reason why we do that is because the brain and the spinal cord can only have so many sensory input at a time. So when nothing else is going on and you're just paying attention to the itchy spot, all you feel is the itchiness. But when you start to scratch that area, then you start to pay attention to it less because the scratching sensation overrides the sensory input of the itching from a mosquito bite. And this is the neurologic paradigm for the gait control theory. So normally when the pain receptors are firing off, it goes through the first nerve structure, then it encounters this junction where sometimes an inhibitory interneuron can help dial down or can dial down the pain. And from that point on, it goes through a secondary neuron, then up the spinal cord and into the brain where we ultimately process the pain. Now, with the gait control theory and neuromodulation, what we can do is we can introduce a stimuli to target things at different levels. So first, we can help enhance the effects of the inhibitory interneuron. So we can help the inhibitory aspect of pain to become more potent. In addition to that, we can also block off some of the painful stimuli and replace it with a different type of stimuli, such as buzzing or tingling sensation. But there are many neuromodulation systems where they're paresthesia-free or subparesthesia, meaning the frequencies are so high that they're barely perceivable. So let's talk about restorative neuromodulation. This is a burgeoning field for which we've been on the cutting edge here at Stanford. These are peripheral nerve stimulators to help re-engage the muscles, reduce pain, and optimize alignment over time. So recall our previous image where we talked about how our muscles can atrophy over time and that there can be malalignment over time. And what we find is that the majority of people with chronic low back pain will have something called multifidi atrophy and low back atrophy. So here is a normal spine. This is if I were to slice you in half horizontally. So here's the front of the spine, here's the back of the spine. These are the muscle groups. So in a normal spine, I jokingly tell my patients, it's almost like a lean piece of meat. There's not a lot of fat stranding. It's just very lean muscle that's dark here. Now, when someone has chronic low back pain, sometimes they can develop anywhere between mild to severe muscle atrophy. And when you get to the point of severe muscle atrophy, this is what I jokingly describe as A5 Wagyu or Japanese Wagyu, where there's a lot of fat stranding that occurs in the muscle. So when there's so much fat stranding in the muscle just isn't able to mobilize in the way that it should. So you'll commonly see patients where they have difficulty with coming from bending forward to coming up, or they feel like they're slower to move with their back. And that's because it's largely due to muscle atrophy that develops over time. And there have been many studies that demonstrate the strong connection between low back pain and a weak multifidi muscle, among other muscle groups. And if you look at this far image on the right here, the low back muscles are responsible for connecting you to the upper part of the body, to your core, as well as the lower part of your body. So when it degenerates, that's when you start seeing some other portions of pain in other parts of your body. So with restorative neuromodulation, we can put things such as peripheral nerve stimulators, just one or two small wires in very specific areas to help re-engage the muscles and try to get patients more functional. Now, let's talk about peripheral nerve stimulation more broadly. That can be using the gait control theory or for restorative neuromodulation purposes. And the goal is to help treat the nerves using the gait control theory like we talked about. There are temporary systems for shorter duration of pain. That typically does not involve any incision, and it's usually 60 days of therapy. And what we do is we go in with a small needle and we put 1 to 2 wires around target nerves, muscle groups, or joints to try to help reduce pain. And oftentimes, a short amount of peripheral nerve stimulation time is enough to break up that circuitry and that positive feedback loop where the focal area of pain ramps up the central nervous system, which then ramps up the peripheral sensory of pain. There are also permanent implantable systems for people who have been suffering pain for longer periods of time, or they have return of pain after they've had a temporary system in place. And typically with these systems, there's a trial that can range anywhere between 3 days to 7 days. And you get to test out the system before you move forth with a permanent implant. And typically this is done with 1 to 2 small incisions, usually 1 to 2 centimeter incisions that you don't even need to stitch together. You just use a bit of surgical glue and everything will heal by itself. And even though we call it permanent implantable system, they are explantable at any time. And these are outpatient procedures and they're performed under light sedation. And you can do this under ultrasound or fluoroscopic guidance. So this is just an image to demonstrate just how small these wires are. So this is about the size of a piece of thread. There are different types of nerve stimulators. Some of them have these types of electrical impulse delivery system, and some just have some at the active tip. And the system what we choose is highly dependent on the type of pain condition. Another treatment option is something called dorsal root ganglion stimulation. And the dorsal root ganglion is a converging point for the peripheral nerves before it enters the spinal canal. So the goal is to try to treat the nerve with stimulation using the gate control theory as well. So what we do is we go centrally and we put small wires around the nerve root here at the converging center. And what we can do is we can reduce the amount of pain by reducing the amount of pro-inflammatory markers as well as the pro-pain markers in the region. And with this type of system, typically we would do a temporary trial, meaning we have the system placed for about 3 to 7 days. There's no incision. You would just have 2 small pieces of thread coming out of your skin and we tape it down. And the device company will work with you and adjust the system to see if this is a viable option for you. And if you do indeed have improved symptomatology as well as improved functionality, then we go ahead and move forth with the permanent implantable system on a separate visit. And typically with this, it's with 0 to 2 small incisions for the wire, depending on the location. And we just have a small to medium incision for a battery pack placement. So it's kind of like a pacemaker for your back. And it's an outpatient procedure performed under moderate sedation. And with the battery pack, there are rechargeable systems and there are non-rechargeable systems. The rechargeable systems will require you to charge it once every so often, and the permanent implantable system, non-rechargeable systems are ones that have to be switched out every 3 to 7 years, depending on how much you use it. And when you do a battery exchange, all you do is you just exchange the battery itself. You don't have to adjust the wires at all. And in addition to low back pain, it can also help with pain in the extremities. Now, there's also spinal cord stimulation where you go even more retrograde towards the central nervous system. And again, you reduce the transmission of pain using gate control theory. And just like the dorsal root ganglion stimulator, there's a 3 to 7 trial where we place temporary wires with no incision. And at the end of 3 to 7 days, remove the incision, the system, and you can compare and see if you have any benefit. And if you do have benefits, then we do a permanent implantable system, and we can do 2 small to medium incisions for the battery and the wires. And again, this is performed outpatient with moderate sedation, and the battery exchange occurs every 3 to 7 years. And just like the dorsal root ganglion stimulator, it can also help with neuropathic pain in the extremities, as well as things like shingles pain, also known as postherpetic neuralgia. So there'll be 1 to 2 small wires in the back connected to a battery generator, and you'll have an external controller where you can turn up, turn down, or adjust the nerve stimulator system to try to help reduce the amount of pain that you're feeling. Now, this is another burgeoning area, which is mid-invasive spine interventions, also known as MIS. And these are interventional spine procedures that are completed with small to no incisions. And they're all outpatient procedures, meaning you walk out of recovery and you return home and you're able to return to normal activities right away. And these are targeted approaches without large alterations to the anatomy of the spine. And they have easy recoveries and they don't burn bridges for larger surgeries if needed. So the first treatment option we'll talk about is something called basivertebral nerve ablation. The goal of this is to treat pain that comes from the front portion of the spine, specifically the disc and the vertebrae. So it's very common for people to have degenerative disc disease at some point in their life. And so normally your disc will be nice and plump with a nice interface between the vertebrae and the disc. Now, over time, these discs dry out. And as the discs dry out, they release inflammatory markers into the vertebrae that's adjacent to the disc. And when that happens, it causes arthritic changes along the bone line and causes some inflammation. Now, the inflammation itself is harmless, but it can sensitize the nerves in the vertebrae and cause you to perceive more pain, even with small movements. And typically, the patients who benefit from basivertebral nerve ablation have pain that exacerbates with mechanical loading of the front of the spine. So that's things like prolonged standing, prolonged walking, bending, or holding groceries. And there are these nerves called the basivertebral nerves where they sense the pain that comes, or the arthritic changes that comes from the end plates here of the vertebrae. So unlike other nerves, for radiofrequency ablation, basivertebral nerves do not grow back rapidly. So it's typically just a one-time treatment. It's not something you have to repeat. And it's performed with 1 to 4 very, very, very small incisions, depending on the number of levels. And it's an outpatient procedure done with X-ray guidance, and it's performed under general anesthesia or sedation. So again, these are the basivertebral nerves. We just enter in with a small instrument here into the bone, and we treat those nerves, and we reduce the sensitivity of those nerves. And over the course of 3 months, we see patients have less and less pain, and they're able to do more. The next procedure in the minimally invasive spine space is something called percutaneous image-guided lumbar decompressions. It's a mouthful, but really it just means you're using a very minute incision to use X-ray guidance to remove small amounts of ligaments in the spinal canal. So the goal is to open up the spinal canal space by removing redundant ligaments. So if you look at this bottom right image here, this is a size of a normal spinal canal. There's a lot of cushioning fluid. You see the nerve roots coming off to the side. Now, this is someone with spinal stenosis where they either have disc bulge or spinal canal compression from arthritis in the adjacent segment. Oftentimes, when there's arthritis in the area, there's overgrowth of something called the ligamentum flavum. And when there's overgrowth in that area, it can also contribute to the compression of the spinal canal. So what we can do with this procedure is that we can try to remove some of the ligaments, and by removing some of the ligaments, you can open up that spinal canal space by a couple millimeters. And sometimes just by opening up by a couple of millimeters, you can allow the nerve roots more room to breathe, and that'll be just enough to allow you to have less pain and less leg fatigue. So spinal stenosis and neurogenic claudication are typically treated with epidural steroid injection and medication. Traditionally, when that doesn't work, we move forth to a lumbar decompression where we remove parts of the bone, plus minus a fusion where we stabilize it after we stabilize the vertebrae level after remove the bone. With this type of approach, we're able to remove one component of the contributing factors to the spinal stenosis. And sometimes that's all we need to help you reduce your leg pain and your back pain. So there's something called the shopping carts sign. And for patients with spinal stenosis, the majority of them will have the shopping cart sign when they're at the grocery store. So that's pain that is worse when you're arching your back or walking for prolonged periods of time. So you'll see these patients lean forward on their grocery cart because by bending forward, you open up the spinal canal space, which can then decrease the amount of narrowing that happens around the spine. And so this all proves that you don't require a lot of additional opening to have significant improvements in functionality. And this is typically done with 1 to 2 small incisions, depending on the number of levels that are being treated. It's an outpatient procedure done with fluoroscopic guidance and performed with light sedation. But I do want to emphasize it's not a substitution for open decompression if there are emergent findings. And sometimes if there are many contributing factors to your spinal canal stenosis, you may actually benefit more from a traditional lumbar decompression with a lumbar fusion. However, our goal as pain physicians are to try to use the least invasive way to help you improve your pain. And so on this bottom image here, this is an example of someone with ligament and flavin hypertrophy. By taking out some of the ligaments in that area, these nerve roots will have more room to breathe. And this is a cross-sectional view here. Sometimes when there's arthritis buildup here, there's ligament and flavin buildup, there's some compression or pressure around the nerves, and there's arthritic changes in the vertebrae. And all of these things ultimately tighten up the space. So by removing one component, you could potentially help reduce some of the symptoms you're experiencing. The next thing we're going to talk about is sacroiliac joint fusion or stabilization. And the goal is to prevent motion that contributes to arthritis-related pain. So sacroiliitis or sacroiliac joint-related pain is actually 30% of all cause low back pain. And that's because the sacroiliac joint is a major joint, and all your weight, after it travels down the lumbar spine, gets transmitted through the sacroiliac joint, then to the hips, to the knees, to the ankles, to the foot, and then to the earth. So because it's this large weight-bearing structure, there's a lot of pressure that's under. So over the years, it will develop some sort of arthritis, and oftentimes the arthritis and degenerative changes can cause pain. Now, what's also notable is that for patients who have had lumbar fusions at the 5-year mark, the literature has demonstrated somewhere between 40 to 75% of this patient population will develop chronic low back pain due to sacroiliitis. So with sacroiliac joint fusion stabilization, the traditional approach is to make a large incision off to the side. You cut down, you dissect the tissue, and then you drill 2 to 3 large rods and screws across the joint. Nowadays, the technology has improved and we have more image guidance. So with this, we can actually accomplish the same thing using smaller incision. And there's a variety of different approaches that we can perform. For some patients, they may benefit from just putting a little door wedge into the sacroiliac joint, just distract the area. And sometimes that small door wedge is all you need to help stabilize the joint and prevent the painful motion from occurring. There's also other ways of helping stabilize that joint. Some ways involve transfixing, either from the back portion or coming in from the side. And a lot of that's highly dependent on the morphology of your sacroiliac joint. And for this procedure, because the incisions are so small and we preserve the native anatomy without causing large dissections to the area, patients are walking out of the recovery area on the same day, and the recovery are much faster. And this is a procedure that's an outpatient procedure and is performed with deep sedation or general anesthesia. So this is just a handful of many of the treatments that we've been treating patients with over the past few years at Stanford with really great results. And I also want to talk about some key takeaways from today's presentation. One is chronic low back pain is very prevalent. You are not alone. Chronic low back pain is often multifactorial. So therefore, the treatment has to be tailored to each individual. And the goal is to improve the function through symptomatic improvement and physical therapy. And many patients respond well to conservative care, injections, and ablation. But if you're refractory to standard therapy, there are other treatment options like neuromodulation and MIS that are great evidence-based treatments for the treatment of spine-related pain. And these advanced treatment options are same-day procedures with 0 to small incisions and quick recoveries. So thank you so much for tuning in and listening to my presentation. I was really excited to really talk about low back pain, what causes low back pain, and the different ways in which we can intervene at various stages of the neural pathway to try to help improve pain. And so this is an area that's a burgeoning area of research just because it's becoming more prevalent with the aging population. So if you or someone else that you know is suffering from low back pain, it's time to take it seriously because we want you to live a very functional and happy and minimally painful life. And you should not deprive yourself of these potential treatment options, especially since they're very low risk and they're very beneficial for the majority of patients. And with that, I'm happy to take any questions with our residual time.
Great. We have some time for a few questions. One is, if you use a pain blocker, do you put yourself at risk for injuring your back without knowing?
That's a great question. So it depends on where the pain blocker is located. Now, most of the sensory receptors in the back that we target in the pain management space are not responsible for things like balance and things like important perception. So because of that, even though we're turning down how those receptors are sensing the pain, they don't contribute significantly, if at all, to important things like balance and knowing where you are spatially. So they do not typically affect these important sensory fibers. That's a great question.
What can you say about chiropractic work and its role in chronic back pain?
I think chiropractic work is great. I see it as a continuum of physical therapy. So there are different types of chiropractic care. Some involve traction devices where they help expand the space. Some involve soft tissue manipulation, electrical stimulation of the muscles to try to help loosen up tension in that area. Now, the main thing with chiropractic care is that there are certain things that can cause some harm. So all my patients who get chiropractic care, I tell them, in general, the treatments are safe. The exception are things with sharp manipulation of the neurologic structure. So that's any sort of sudden jerking movements that are performed, because sometimes when you do sudden jerking motion, you can actually cause shearing force on the blood vessels. And when that shearing force happens, people can develop strokes and sometimes can even develop to paralysis. So from that perspective, I really encourage patients to be careful with the providers that they work with because there are some potential harm that can happen. Now, outside of that very specific example, for the most part, manipulation of the musculoskeletal system can help reduce pain. So in general, I actually encourage people to try it before they consider something more advanced.
Can you comment on decompression therapy?
So it depends on different types of decompression therapy. So if you're talking about chiropractic care specifically, that's usually with a traction device where they stretch out the spinal column to help the area breathe. Now, the main limitation of that therapy is sometimes they're not able to facilitate traction in a way that's going to cause meaningful opening of the spinal canal space. In addition to that, oftentimes the therapies are short-lived because when you're up and walking, that space compresses again. Now, other types of decompression are traditional surgical decompression, where they remove parts of the bone and debris in the area, and sometimes they'll fuse that area. We know that that is the most robust way of helping the nerves breathe and reducing stenosis around the spine. However, the trade-off for that is for some patients, it could be much more challenging to recover from. But there are also invasive surgical approaches to that from a traditional surgery standpoint. From our standpoint, there are different device and instrument system that can allow us to just adjust the height of the spine a little bit or improve the alignment of the spine or remove some debris in the area to give it just enough space for the spinal canal to breathe. So there are different ways of decompressive surgery, decompressive therapy from that standpoint.
Do you have any recommendations on how to address the root cause of back pain in your youth or before middle age?
That's a great question. So going back to a previous slide, you'll see that even for people without any sort of pain, you'll see some degree of degeneration. So what that tells us is that degeneration does not always equal pain. So to get to the root cause of the pain, it's really multifactorial. Sometimes there are specific variables that are very clear on the imaging, and with provocative maneuvers on your physical exam, it's very clear it's coming from a specific spot. So with that, sometimes all we have to do is do a simple intervention in that area and you feel better. But like we talked about in previous slides, usually when there's deterioration in one component, the adjacent segments will have some deterioration as well. So the decision becomes trying to treat the primary source of pain. And sometimes with just treating the primary source of pain, the other areas are manageable. But sometimes when we treat the primary sources of pain, the adjacent segments become more noticeable, in which case we would treat those areas. Now, for my younger population, I tell them, you always should partake in exercise-based therapy because exercise therapy will help you strengthen your back and prevent abnormal movement of the spine. And by optimizing the alignment of the spine, you prevent early onset arthritis and degeneration in that area. Some degree of degeneration is inevitable, as we've seen from the studies, but you can slow down the process significantly. And even for our older patients, we still encourage them to partake in physical therapy because by exercising, they can prevent things from progressing, and they can also reverse some of the pre-existing issues that occur in that area.
Well, thank you so much, Dr. Liao, for sharing this great information. And thank you to our audience for joining us. If you still have a question, please feel free to reach out to the health library and we'll connect you with some resources. And this lecture will also be posted on YouTube in about 1 week's time. So if you'd like a copy of it, please join us on there. And we hope to see you at our next lecture.
Fantastic. Have a great evening, everyone. Thank you for joining us.